Again, Dr. Luktish, thanks for this opportunity. Manisha was supposed to give this, but she was not able to be there. So the disclosure is a scientific grant from Boston Scientific to the university, primarily to study the stents in esophageal perforation, also the design of stents. So just want to cover the background for esophageal perforation, presentation, use of stents, as well as the results of treatment. So this is a review by Andrade and Mattis. And basically, the perforated or leaking esophagus, whether it's from caustic injury or any other reason, is a highly morbid condition. And the mortality can be up to 50%. But with improvements in technology and critical care, the morbidity has significantly decreased. But still, it's a high mortality or morbid condition. So one of the papers which is highly quoted in the literature came out of Hopkins and University of Chicago in 1980 by three-author paper, Skinner, Little, and DeMeester, 47 patients which they treated, and all of them were personally taken care of by them. And there was an 80% survival in those 43 patients who had esophageal perforation, and it was thought to be a big improvement, in terms of the survival of these patients. Prior to that, it was much higher in terms of the mortality. Subsequently, Ginsburg and Jones did about 10 years later did a review of almost 600 patients, and they found that the mortality rate was still significant, about 22%. And so it was also in the series, they noted that about 20% of the patients were managed by non-operative methods. And Kurgan put together again an update of Dr. Little's experience on esophageal injuries and reported a 90% survival or 10% mortality, which is one of the lower mortalities which is presented in the ISDE, again in the early 1990s. And I'm going to skip through some of this thing in terms of the etiology, but the common etiologies are iatrogenic, mainly for endoscopies and dilations, and that's what we see. And we also, the other common etiology is Boerhaave syndrome, which surgeons see. And there are various other things such as caustic injury and perforated ulcers, etc. And in Boerhaave syndrome, there's a rapid increase in intradural pressure, and for the people who had helped in the operating room for a Boerhaave's, the perforation is classically in the distal esophagus, and it's it is on the posterolateral aspect of the distal 6 centimeters of the esophagus. And these patients have a history of emesis followed by chest pain and subacute emphysema, and they also have changes of sepsis, mental status changes, etc. So this is a barium swallow showing a leak in the distal esophagus and a little bit of a pleural effusion. And this is another patient actually of mine, which we treated at Mercy a couple of years ago, and a big hole in the esophagus, and literally half the chest is full of contrast. So the principles of management, and we can talk about what are the various options, but the main principles are, first is to control the perforations, and the various options for that: wide drainage, antibiotics, and nutrition. I think those are the four main things. And then the actual management, of course, depends upon the patient status, contained versus non-contained leak, status of the patient, and the nutritional status of the patient. So these patients can progress quickly into septic shock, and this requires really a multidisciplinary approach with our team as well as the critical care team, following the patient, very closely. And we pretty much put all of them on antibiotics the moment they hit the door, and decide on the best course of action to control the leak. Non-operative management can be successful in about 25% or described up to 25% of the patients, but majority of them require some kind of intervention to control the leak. So what are the criteria for non-operative management? This comes up frequently in the boards, is it should be a contained leak with the leak draining back into the esophagus. And the injury should not be through cancer, and also there should be no distal obstruction with a stricture. And the patient should not have any signs of sepsis. So these patients can be just managed by antibiotics, IV fluids, and careful monitoring. But this is about 20% of the patients. And this is, again, another review which summarizes this. So what are the options in terms of surgical management? And I think the number one thing in terms of the surgery is a primary repair with a buttress. And I think we almost all have this shared. Patients have done a few with Benny and Sarkaria and Omar Owais and others. And these are all literally the middle of the night. And there are complex patients which we repair with a buttress. And the main thing is to debride until healthy tissue and do a primary repair in 2 layers. And we generally like to put a feeding jejunostomy tube and a draining gastrostomy tube. And this is the classical thing where we, let me see if this works. Sorry. Yeah, so you mobilize this to the left chest, you mobilize the distal esophagus, and importantly, you go to the right chest. If there's an effusion, you can drain the right chest through the left. And in terms of the mucosa, you have to open up the muscle so that you identify the edges where the mucosa is actually torn, and then you have to repair the injury. Otherwise, you're not going to see the full extent of the injury. And typically, we use a muscle flap to close these perforations. And this is the primary repair. That one is set on the right-hand side is the muscle which closes that. The other option is the T-tube drainage, which we tend to use, particularly if you're worried about whether or not the perforation is going to heal, and we close this perforation over a T-tube. And this has been well described in the literature too. And of course, we talked about a gastrostomy and a jejunostomy tubes. Now, if the patient is in dire straits, the other thing is exclusion and diversion, which sometimes we have to do on patients with caustic injury, typically. And esophagectomy, again, emergent esophagectomy for this is rare. I think that we have used the transhiatal approach in benign esophagus to remove the necrosed esophagus with the patient lying in supine position, at the same time addressing other pathology in the abdomen. So this is the use of the stent, and that's more and more becoming more frequent. And the main thought is to use a stent at least more than 21 millimeters so that it stays there, and a fully covered stent may have some advantages. The proponents of the stent talk about an earlier PO intake as well as the potential for less dilations. And this is a paper we're using a polyflex stent many years ago, which you present. This is a combined Michigan and Pitt series. We had 58 patients whom we used the stent, of which about 13 patients had a leak or a fistula. And what we found was it was successful in about 6 of the 8 patients, the leak or the fistula, but really failed in 25% of the patients. And the majority of the failure is because the stent migrated. However, there were also cases when the fistula actually got worse because of the radial expansile force of the stent. So the stents are not exactly benign, but the main issue with them is migration, and we talked about various things to anchor the stent. But the expansile force can also worsen the leak, so that is something to keep in mind. I'm going to skip on the results of this thing on the polyflex sense. And Dr. Freeman is the main investigator who's prospectively studied use of stents. And so the more important issue is when to not use a stent, because these days we think about a stent in almost every patient. So he, on his analysis of close to 200 patients, injury greater than 6 centimeters, one which traverses the GE junction, and also associated with the leak in the gastric conduit. This is on patients with esophagectomy. Those are the times when the stent failed. The other series was from Mike Mattis's group, and they looked into total of 15 perforations and about 20 leaks. But one of the things which Mattis always emphasizes is just not putting the stent, is actually when he is, it's a post-stent management. Once you put the stent, what do you do after? And the main thing is to make sure you anchor the stent and also not leave it in for more than 2 or 3 weeks. And generally, we remove it over an over tube, once you put the stent in. And I think John had put the series together with a 60% success rate for the perforations, and a leak also was about the same, 60%. But notice the mortality is still about 6 to 14% of patients. So I think the stent is a viable option in some patients, but we still have to drain the chest. So this is the UPMC series, and I think that many in the audience have contributed to this. 120 patients over a 10-year period, and the median time when they presented to the UPMC was about 12 hours, and Borhaus was in 1/3 of those patients. 2/3 were iatrogenic perforations. And what we found was the mortality on the series was about 14% overall. So it's still, we talk about the mortality of esophagectomy, et cetera, but esophageal perforation at UPMC or elsewhere, what you're seeing, has a significant mortality. And so this is something which needs to be taken care of very seriously. For the patients who had Borhaus, on this series, everyone we operated. We didn't use any stents. However, for patients with iatrogenic injury, some of them we used it as a stent, some of them we used primary repair. We also devised, and this is a lot of the work was by Dr. Landreneau, Schukert, and others, looking at setting a perforation score. And very simple variables, easy to collect, such as heart rate, age, blood pressure, whether it's a contained leak or no contained leak, and came up with a score, in terms of their mortality. Now, we don't routinely apply it on every patient, but this is a retrospective analysis. And here you can see on the left-hand side is a small contained leak, and the right-hand side you can see some contrast in the chest. And the mortality seems to correlate with this particular score. So 10% versus 16 versus, 2% versus 27% for the category 3. And so although there are some patients who can be managed non-operatively, we thought that this could help decide how sick the patient is and how aggressive the treatment needs to be. Now, interestingly, we were quite surprised and shocked to see the AATS that the Europeans, we didn't have this tested in the US so far, but the 10 countries in Europe picked up on the Pittsburgh score, and we were pleasantly surprised to see that they wanted to check they set spotlight on the Pittsburgh esophageal perforation system. And it was a big study, and they said the Pittsburgh group had suggested the PSS for decision making, and they wanted to see across 10 different countries in Europe whether this system held. So this was a 14-year study, almost 300 patients. Again, the majority of these patients were Borhaus, and then there were other iatrogenic patients. And what they found was, in this independent group of patients, that the Pittsburgh strata successfully stratified the morbidity, length of stay, as well as the mortality of esophageal perforations. And so this is their data, which was subsequently published in the JTCVS. The mortality for on the lowest category was over 3% versus 37% for the higher risk patients. So it's been, we can say, independently validated in 10 different countries with this particular study. So I think that from our standpoint, we still want to refine this, and of course, this is the European study's conclusion that the study successfully stratifies patients. So, and they also came with an algorithm based on the score. So I think that in summary, the management of esophageal perforation is complex. Treatment should be individualized, and I think that the principles basically are to control the perforation, whether it's by surgical repair or by stent, but also do wide drainage. It could be with a laparoscopy, with thoracoscopy or a thoracotomy, antibiotics and nutrition. And then also one of the important factors is how the patient is, which is factored into the Pittsburgh score. And these are some of the options. And I think that's it, extent summary, and so treatment we feel should be individualized. So thank you all very much. One thing I also wanted to mention, it didn't include this in the topic, is the use of a sponge, which I think Ryan Levy has used in a few, which, a vacuum sponge for the perforation. I know he's used in the setting of a leak, but I don't know whether that has been used in the setting of a perforation. But that's an area of emerging interest, particularly on the leaks. Any comments, Ryan?
Perforator in the GI lab, but she had about a 3.5 to 4 centimeter perforation into the mediastinum. She wasn't in good shape, so we managed her endoscopically with just a peg, a disimpaction, a mediastinal washout through the endoscope, and then endoluminal wound vac and esophageal stent placement, where we went back to the OR every week for 4 weeks, and she's completely healed and eating within 4 weeks. So and all she got was bilateral chest tubes, so no VATS, no decortication, no flap, nothing.
So this is like, so you use it for control of the leak and to drain the mediastinal collection.
Yeah.
Okay, I mean, so it may be something which, Benny, have you used something like that? Yeah. Oh, really? Okay.
So some were for esophageal leaks.
Yeah.
And others for esophageal perforation on very, very elderly patients that I thought would do poorly. For leaks, it works in particular for those patients that end up with a large cavity beyond the leak.
Yeah.
Because then the endosponge end up, and I don't know if that's Ryan's experience as well, the endosponge end up collapsing that that cavity. Now, that is not commercially available. You have to kind of MacGyver it with an NG tube and the sponge, and it's...
So for 4 weeks, if you leave an NG tube on suction, is that a little bit of a challenge with some of these patients?
I change it every at least 4 or 5 days.
Change it every
Yeah. You got to look and see, make sure it's in place. I don't know what Ryan did in his cases. Yeah. So you do need to change it, but it's not.
How often are you changing, Ryan?
weekly.
Yeah, I've sent a patient home with it, and they would come as outpatient. And
Yeah. Is there, in terms of the suction, how much suction do you apply? There's the pericardium, there's aorta, etc.
I use
when you put the sponge there.
125. I just use it with a vac, 125.
Really?
Is that what you use, Ryan?
Usually the first week we don't go that high, we're 75.
Yeah.
And is it like a white sponge?
Black sponge.
Black one, okay.
Works great.
It works great, okay, great.
And there's a commercial device in Europe, I believe.
Yes.
It's actually for, the device was for leaks after APRs. And then it was used in the esophagus. It's called the endosponge. And it's by B. Brown, but it's not commercially available here.
CE marked, not FDA. Any other questions? Thank you very much.
Okay, thank you very much.